Uterine fibroid is the commonest benign solid tumor of the muscular wall of the uterus, composed primarily of smooth muscle and fibrous connective tissue. Also called as uterine leiomyoma, myoma, or fibromyoma. According to the National Institutes of Health, about up to 80% of women have fibroids by the age of 50. Fibroids affect around 30% of all women by the age of 35 years, and from 20 to 80% by the age of 50 years. However, most women don't have any symptoms and may never know that they have fibroids. They usually develop between the age of 16 to 50 years. These are the reproductive years during which estrogen levels are higher. The etiology still remains unclear. In the past, it was considered that it's an estrogen-dependent tumor, but nowadays we see that it's an estrogen and progesterone-dependent tumor, the major growth of which occurs in reproductive age. After menopause, the fibroid shrinks and its development is infrequent. Risk factors of developing fibroids are early menarche, nulliparity, increased BMI, family history, and ethnicity. Here you can see the types of fibroids. We divide them into uterine fibroids, which include intramural or interstitial, submucosal, and subserosal fibroids, and extrauterine fibroids, which grows in the cervix or broad ligament. Here you can see the classification of the fibroid by the FIGO. Number 0, it's pedunculated intracavity fibroid. Number 1 is less than 50% intramural. Number 2, more than 50% intramural. Number 3, contact endometrium and 100% intramural. Number 4 is intramural. Number 5 is subserosal and more than 50% intramural. Number 6 is also subserosal but less than 50% intramural. Number 7 is pedunculated subserosal fibroid. Number 8 is a fibroid which grow in the cervix or broad ligament. Here in the picture, you can also see the fibroids from number 2 to 5. It is submucosal and subserosal fibroids. Each was less than half the diameter in the endometrial and peritoneal cavities, respectively. Intramural fibroids are the most common type of fibroid. These types appear within the muscular wall of the uterus. Intramural fibroids may grow larger and can stretch the womb. Subserosal fibroids form on the outside of the uterus, which is called the serosa. They may grow large enough to make the womb appear bigger on one side. Here on the picture, you can see the subserosal fibroids with different localization. This one is pedunculated subserosal fibroid. Submucosal fibroid is this type of tumor that develop in the middle muscle layer or myometrium of the uterus. Submucosal tumors aren't as common as the other types. Now we'll talk about the clinical features of the uterine fibroids. As you know, the symptoms of the fibroids depends on localization and the size of fibroid, but mostly it means 75% of fibroids remains asymptomatic. But if our fibroid starts growing, women will have some symptoms depending on the type of fibroid. The most common symptoms are menstrual abnormalities like menorrhagia and metrorrhagia. Metrorrhagia, it means the irregular menstrual cycles. Dysmenorrhea, it means the pain during menstruation. Dyspareunia, it means pain during intercourse. Infertility, lower abdominal or pelvic pain, abdominal enlargement, frequent urination, and constipation. Now I want to tell you that if woman has serosal fibroid, woman will have these kind of symptoms like frequent urination or constipations. If the fibroid localized on the anterior part of the uterus, a woman will have frequent urination because fibroid will press the bladder. But if the fibroid on the posterior side of the uterus, woman will have constipation because fibroid will press intestine. What about intramural fibroid? The most common symptom of intramural fibroid is menorrhagia and also dysmenorrhea, dyspareunia. And the most common symptom of submucosal fibroid is prolonged heavy bleeding and also infertility. What we have to do to diagnose the fibroids? First of all, it's history taking. After history taking, we should do pelvic examination, ultrasound. If these methods are not informative, we can do pelvic MRI, hysteroscopy, or laparoscopy. But mostly during pelvic examination or ultrasound, we can identify that woman has fibroid. Also, you should know that we should differentiate this disease with polyps, adenomyosis, endometriosis, and uterine sarcoma. The treatment of uterine fibroids depends on the age, on the parity, on pregnancy status, desire for future pregnancy, general health of the woman, symptoms, size, and location. Here you can see that we have three main steps of the treatment of the fibroid. First of all, it's medical therapy. Then we can do surgical therapy or non-surgical alternatives like uterine artery embolization, magnetic resonance guided focused ultrasound surgery. Now we'll discuss about management of fibroid. Our management depends on the localization, first of all, because if our fibroid localized in the body of the uterus, we will see if the fibroid is asymptomatic or symptomatic. If it's asymptomatic and size less than 12 weeks, and we know the exact diagnosis of this woman, we should do regular supervision, like we should check the size increases and the symptoms. If the size increases and the symptoms start appear, we'll do surgery. But if the size of fibroid is stationary and symptoms are less, we'll do follow-up. If the fibroid is more than 12 weeks and it's still asymptomatic, but we don't know the certain diagnosis of the woman and woman has unexplained infertility, then we do surgery. If it's symptomatic, we will choose medical or surgical treatment. Now we'll talk about symptomatic fibroid. If we talk about medical treatment, first of all, we should treat anemia and we should use fibrinolytics. Indications for medical treatment is if our patient is symptomatic, if it's perimenopausal female, woman desiring children and retaining uterus for correction of anemia before surgery and to decrease size and vascularity of tumors. If we will talk about surgical options, we have several types of surgical options. First of all is myomectomy, second hysterectomy, myolysis, or embolotherapy. We can do myomectomy by endoscopy, laparoscopic myomectomy, hysteroscopic myomectomy, or just laparotomy. No treatment is required for asymptomatic small fibroid unless it causes 12-week uterine enlargement or is the cause of infertility. For excessive heavy cycle, progesterone-only therapy, it's oral contraceptives, progesterone-only pills, or levonorgestrel-releasing IUDs. Combined oral contraceptive pills used cyclically to reduce menstrual blood loss or continuously to eliminate the cycle. Dysmenorrhea is also improved. Now we'll talk about surgical measures. Operative treatment, we call it myomectomy. Indications for myomectomy is women who wish to maintain fertility, the submucosal fibroid distorting the uterine cavity, fibroid more than 5 centimeters, and multiple fibroids. We can do open myomectomy, the route of choice for large subserosal or intramural fibroids more than 7 centimeters, multiple fibroids more than 5 centimeters, and when entry into the uterine cavity is expected. We can also do hysteroscopic myomectomy, the route of choice for submucosal fibroids, for removing submucosal fibroid more than 2 centimeters. Also, we can do laparoscopic myomectomy, mostly done in subserosal type. Remove the mass through a small abdominal incision. Hysterectomy is indicated for old age women who completed her family and who has multiple fibroids. On this picture, you can see the uterus after hysterectomy was several, it means multiple fibroids. As I told before, we have also non-invasive procedures. First of all, it's uterine artery embolization. The ideal patient for this method is premenopausal patient not desiring fertility, postmenopausal patient with failure of spontaneous regression, patient has failed medical management, and also absolute contraindication to surgery. Second type of non-invasive procedures is MRGFUS, focused ultrasound wave converted in pathology to heat under guide of MRI. Selection criteria is fibroid 4 to 10 centimeters if the family is completed, and also perimenopausal women. Thank you for your attention.